Over to you, Shubhashri.
Yes, ma'am. Good afternoon, one and all present here. On behalf of Niche, I, Shubhashri Joshi, Junior Executive of Niche Advocacy Foundation, welcome you all. Niche Advocacy Foundation is a youth-centric organization for focusing on emotional fitness and personal growth. The primary aim is to stimulate individuals and the community for personal growth, where N in niche stands for neuroplasticity, I stands for individual, C stands for community, H stands for health, E stands for education, and A stands for advocacy. There are three main pillars of niche, which are unhide, samvad, saksham. The purpose of Unhide is inspiration through interaction. Under Unhide, we have various programs and events like expert talk, question and answer panel, debates, many more. Under Samvad, we have outreach programs like Rishto Ka Manja, Manaranga, Manthan, which is our podcast, and etc. Saksham, the purpose of Saksham is the third pillar is Saksham, and the purpose of Saksham is empowerment through education. Also, under Saksham, we have various skill programs, workshops, ITMs, caregiver programs, etc. Also, we are coming upcoming project of niche are NeuroHub Center and Splash the personal retreat. You can also check our website nichefoundation.in for further details, and also for upcoming event you can check our Facebook and Insta page. Now, without wasting a minute, I would like to give introduction of our first speaker, Dr. Purnima Gauri ma'am. She is a consultant neurologist in Pune and Nagpur. She is the director of Niche Advocacy Foundation. She is neurologist with a holistic approach who enjoys counseling and thinks it is an integral part of treatment in neurology. She is an passionate worker about emotional fitness and personal growth. She is an active writer, singer, and artist. She works diligently for social engineering through the social profit company Niche Advocacy. She is also an assistant professor at Department of Neurology in Bharatiya Vidyapeeth Medical College and Hospital. She is also consultant neurologist attached to Jupiter Hospital and Joshi Hospital, Pune. So let's start about stroke, and I would like to call Purnima ma'am to give her expert talk. Welcome ma'am, over to you.
Thank you, Shubhashri, for your very enthusiastic introduction. And so here we are talking about stroke on the occasion of World Stroke Day. So World Stroke Day was on the 29th of October, but because it was a weekday, we did not take our program on that particular day. So Sunday being relaxed, we thought we should update everybody's knowledge on stroke. And advocacy means creating awareness, campaigning for the rights of a particular concept. So now here we are creating awareness for brain stroke because unlike what people feel, brain stroke is one of the important causes of death. Even in a tribal area like Gadchiroli, my colleague did a research over there and they did verbal autopsies. And even in a tribal area, they found Dr. Yogesh Kalkonde and his team, they found that the leading cause of death over there was brain stroke. In the current COVID pandemic, we have found that the coronavirus leads to a flare up of immunity, and that flaring up of immunity causes blood to become thicker. And we have found, even while the COVID pandemic was going on, our neurology work did not go down because we were getting cases of stroke. We were getting cases of brain stroke. One of the young patients I saw from the locality of Parvati area in Pune was just a 20-year-old guy. He had had COVID 15 days ago. He had apparently improved, and then he went into this phase of a vascular complication. Similarly, we have had patients collapsing suddenly because of cardiac causes. So basically, blood became thicker and it started choking up blood vessels. And that has led to the increased rise of young strokes even in the COVID pandemic. Now, the brain is amazing, and I have a small little presentation on that concept. So, here I am talking to you about the amazing brain, because without understanding the brain, we cannot understand stroke. So, our identity is not because of the way our nose is shaped or the way our skin is colored. It is actually because of our persona, our personality, about the work we do, about the qualities we have. Actually, our identity is because of that. Our face is just there, except for people who are in the industry of films and beauty. Their personality is because of their face, because their face is their work. Otherwise, all these people, they could have had any face, and their persona would have affected the world similarly. So usually it is our work, our persona and our personality which determine our identity. There are 100 billion neurons inside our brain, as many as the stars in the entire galaxy. Unfortunately, the brain, which looks after the whole body, cannot feel its own pain. The neurons do not have pain receptors, and that is the difference between brain stroke and a heart attack. Because in a heart attack, the first symptom the patient has is chest pain, and he immediately, the pain makes him rush to the hospital immediately, because the pain is unbearable, and the pain drives the patient to seek out help. But the brain does not have pain receptors, which makes the patient feel कि अरे जाने दो, anyway इसमें कुछ नहीं कर सकते, रिश्तेदार बताते अरे ये तो लकवा आ गया, कुछ नहीं होगा इसका, and the patient is not feeling pain all the time. And that is why very often patients reach the medical attention very, very late. And that is not how brain stroke should be handled. The brain has a very unique working system. It has got chemical and electrical messenger system. And with this, the neurons communicate with each other just like the software of a computer or our smartphone. So the brain is the original smart device that nature has given us. Smartphones तो अभी आ गए दुनिया में, अभी 10-20 साल पहले, मगर उसके पहले से ही हमारे पास एक स्मार्ट डिवाइस है, और वो है हमारा दिमाग. और वो दिमाग इतना शक्तिशाली संगणक है, इट इज सच अ पावरफुल कंप्यूटर दैट इट कैन डू एन नंबर ऑफ एक्टिविटीज एट द सेम टाइम. राइट नाउ एज आई एम टॉकिंग टू यू, you are also thinking of something, you are sitting, you are moving your hands in a particular way, you're looking at something, you're listening to something. At this given moment, your brain is doing more activity without your realizing. The brain knows where the foot is kept, where the hand is kept, आंखों को क्या दिख रहा है, कानों को क्या सुनाई दे रहा है, हाथ को क्या स्पर्श हो रहा है. Everything the brain is knowing right now. So the brain is a very active organ. बहुत काम कर रहा है कि शरीर के 2% उसकी वेट है. The weight of the brain is only 2% of the body, but the blood it consumes is 10 times that of its weight. The blood it consumes is 20% of the body's energy. The blood, the oxygen, the glucose that the brain consumes is 20%. और वजन क्या है उसका? सिर्फ 2%. So the brain is so active. It is one of the most active organs of the body. And it does not rest when it sleeps. It just does another type of activity when it sleeps. तो नींद में दिमाग के करने के काम अलग होते हैं, और जब हम जग रहे होते हैं तब दिमाग के करने के काम अलग होते हैं. And the human brain produces as many as 12,000 to 50,000 thoughts every day, depending on how deep of a thinker a person is. तो कितना आप सोचते हो, उसके हिसाब से 12,000 से 50,000 तक सोच आपकी दिमाग में आती है एक दिन में. So that is the amount of work a brain does. Now, this is another important thing to understand, even what our next two speakers are going to say. Now, the work distribution, काम बांटा गया है ब्रेन में. लेफ्ट साइड ऑफ द ब्रेन डज अ पर्टिकुलर टाइप ऑफ वर्क, राइट पार्ट ऑफ द ब्रेन डज अ पर्टिकुलर टाइप ऑफ वर्क, द फ्रंट ऑफ द ब्रेन डज अ पर्टिकुलर टाइप ऑफ वर्क, द बैक ऑफ द ब्रेन डज अ पर्टिकुलर टाइप ऑफ वर्क. ये जो हिस्सा है पिछला वाला, ये दृष्टि का केंद्र है, विजुअल कॉर्टेक्स. दिस इज द विजुअल कॉर्टेक्स. प्री फ्रंटल लोब इज द डिसीजन मेकिंग सेंटर ऑफ द ब्रेन. यहाँ पे मोटर स्ट्रिप है, मतलब वो शरीर के हिलने का नियंत्रण करने वाली जगह है. मोटर स्ट्रिप कंट्रोल्स द मूवमेंट, अल्टीमेट मूवमेंट ऑफ द बॉडी. व्हाट मूवमेंट हैज टू बी डन इज डिसाइडेड बाय द प्री मोटर कॉर्टेक्स. और वो सारे डिसीजंस they are taken based on the sensation going on in the body, which is there in the sensory cortex, and this is the sensory strip. And the left brain controls the right half of the body, the right brain controls the left half of the body in most of the people. And left brain is dedicated to language in most of us. In the left-handed people, it is reverse in many of the left-handed person, but even in left-handed persons, we sometimes find that language can be on the left side itself. This Dr. Sonal Chitnis will be also talking on language. So scientific skills, analytical reasoning skills are present on the left side. Mathematics, there is a special area over here which is dedicated to mathematics. Logic and reasoning are supposed to be originating from left side of the brain. Whereas the right side, Einstein had said that the creative brain is the master and the analytical brain is the servant. But we in our education system have forgotten about it. हमको लगता है एनालिटिकल ब्रेन, मार्क्स मिलना ही हमारी मास्टरी का प्रतीक है, मगर वैसा नहीं है. तो ये क्रिएटिव ब्रेन कहाँ पे है? वो है राइट साइड में. राइट साइड में है स्पेशल अवेयरनेस, म्यूजिक, आर्ट, क्रिएटिविटी, इमेजिनेशन, अंडरस्टैंडिंग डायमेंशंस. ये कमरा कितना गहरा है, कितना बड़ा है, मुझे अगर यहाँ से नीचे जाना है तो मैं कैसे जाऊंगी? पहले मैं उठूंगी, फिर लेफ्ट टर्न करूंगी, फिर दरवाजा खोलूंगी, फिर लेफ्ट टर्न करूंगी. अंडरस्टैंडिंग दीज डायरेक्शंस, विजुअल स्पेशल ओरिएंटेशन इज द वर्क ऑफ राइट साइड ऑफ द ब्रेन. तो जब राइट साइड में स्ट्रोक होता है तब एक्चुअली इट इज मोर चैलेंजिंग समटाइम्स टू रिहैबिलिटेट. रिहैबिलिटेशन मतलब पुनर्वसन करना. जब राइट साइड में स्ट्रोक होता है तो विजुअल स्पेशल डिसोरिएंटेशन की वजह से उसमें से पेशेंट को बाहर लाना मुश्किल हो जाता है. एंड एज आई सेड, दिस इज द अगेन द वर्क डिस्ट्रीब्यूशन. इतना सुंदर काम बांटा हुआ है दैट लर्निंग न्यूरोलॉजी इज लाइक लर्निंग सोशियोलॉजी, क्योंकि इतना काम बांटा हुआ है कि ये जगह जो है वो सिर्फ पैर को का नियंत्रण करेगी, ये थाइज का, ये बटक्स का, ये हिप्स का, ये ट्रंक का मतलब छाती और पेट, ये आर्म का, हाथ का, ये अंगूठे के लिए इतनी बड़ी जगह दी है ह्यूमंस में, बिकॉज वी कैन ग्रिप लाइक दैट. We can grip like that. Because of that we can create things with our hands. और ये उंगलियों के लिए इतनी जगह दी हुई है, चेहरे के लिए इतनी जगह है, और मुंह, जबान और वॉइस बॉक्स के लिए जगह दी हुई है क्योंकि हम बात करते हैं. और इसके अलावा जैसे मैंने कहा कि भाषा के लिए केंद्र है, बोल पाने के लिए एक केंद्र है सामने, और समझ पाने के लिए एक केंद्र है पीछे, पढ़ पाने के लिए एक केंद्र है, और लिख पाने के लिए एक केंद्र है. सो ऐसे अलग अलग केंद्र ब्रेन में है. वर्क इज ब्यूटिफुली डिस्ट्रीब्यूटेड. इट इज अ डिस्ट्रीब्यूटेड नेटवर्क्स apparatus which is working all the time. And blood supply, beautiful blood supply of the brain, क्योंकि नेचर ने एक वहाँ ट्रैफिक सिग्नल में जैसा सर्कल होता है, देयर इज अ ट्रैफिक सर्कल. जैसे नागपुर में 8 रास्ता चौक है, पुणे में सारसबाग के सामने एक सर्कल है. तो सर्कल की वजह से क्या होता है? सिग्नल्स नहीं होते. और सर्कल की वजह से क्या होता है कि जहां जिनको ज्यादा मात्रा में जाना है वो जा सकते हैं, जहां कम मात्रा में जाना है वो वहां कम लोग जाएंगे. सो एज आई टोल्ड यू, ब्रेन का काम इतना डिस्ट्रीब्यूटेड है कि अभी मेरी बात करने की जगह काम कर रही है, और आप सब लोग जो ध्यान देके सुन रहे हो, आपकी समझने की जगह काम कर रही है. तो मेरे ब्रेन की अलग जगह काम कर रही है और आपके ब्रेन की अलग जगह काम कर रही है एट दिस वेरी मोमेंट. तो मेरे ब्रेन का ब्लड सप्लाई और आपके ब्रेन का ब्लड सप्लाई अलग है. जो भी यहाँ आया है और सुन नहीं रहा है, उसके ब्रेन की अलग जगह काम कर रही है. प्रॉबेबली समवन इज चेकिंग मोबाइल और समथिंग, तो उसके ब्रेन की अलग जगह काम कर रही है, और क्योंकि अलग जगह काम कर रही है, उसके सर्कल ऑफ विलिस में अलग तरीके से ट्रैफिक घूम रहा है ब्रेन का, ब्लड का. तो ब्लड, रेड ब्लड सेल्स, ग्लूकोज, ऑक्सीजन, ये सब सामान इधर से उधर जा रहा है सर्कल ऑफ विलिस से. वो हम सब के ब्रेन में हम क्या कर रहे हैं उस हिसाब से ब्लड अभी सर्कल ऑफ विलिस में घूम रहा है. ये इतना सुंदर निर्णय लिया हमारे नेचर ने, और इतना सुंदर ये काम किया हुआ है. तो इसकी वजह से, सो नेचर इज ट्राइंग टू प्रिवेंट ब्रेन स्ट्रोक. नेचर इज ट्राइंग टू प्रिवेंट ब्रेन स्ट्रोक बाय क्रिएटिंग दिस सर्कल ऑफ विलिस कि भैया ये ब्लड वेसल अगर यहाँ से ब्लॉक हो गई तो इधर से ब्लड जाएगा, ये ब्लड वेसल ब्लॉक हो गई तो इधर से ब्लड जाएगा, ऐसे घूम के. सो जैसे ट्रैफिक सर्कल होता है वैसे ये सर्कल ऑफ विलिस है. बट समटाइम्स द ब्लड वेसल्स हियर कैन गेट ब्लॉक्ड, कैन गेट रप्चर्ड. So I'm going to stop sharing the slide show now और मैं ही आपसे बात करने वाली हूँ. और मुझे आपको ये बताना है कि ये सुंदर तरीके से जो वर्क डिस्ट्रीब्यूशन किया हुआ है उसकी वजह से ब्रेन हैज डिफरेंट एरियाज फॉर डिफरेंट वर्क. और समाज में क्या लगता है पक्षाघात या लकवा, लकवा मतलब क्या कि हाथ ऐसा हो गया, मुंह ऐसा हो गया, जो एक्टिंग करते हैं फिल्मों में एक्टर्स की लकवा दिखाने के लिए ऐसा ऐसा करके ऐसे 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 बात करते हैं. बट दैट इज ओनली वन टाइप ऑफ स्ट्रोक. वो लकवे का सिर्फ एक प्रकार है. और जैसे खेत में पानी जाता है तो पाइप सिस्टम होती है, तो पाइप को क्या क्या हो सकता है, पाइप ब्लॉक हो सकता है या पाइप फट सकता है. पाइप ब्लॉक क्यों होगा, क्योंकि वही के वही कचरा जमा हो गया और वो कचरे की साइज बढ़ती गई. ये क्रिया जब हमारे ब्लड वेसल में होते हैं तब हम उसको बोलते हैं एथेरोस्क्लेरोसिस और एथेरोथ्रोम्बोटिक स्ट्रोक. वहीं पे कचरा जमा हो रहा था कोलेस्ट्रॉल का और उस कोलेस्ट्रॉल के कचरे के ऊपर ब्लड क्लॉट का लेयर आ गया एक दिन और उस ब्लड क्लॉट के लेयर की वजह से वो जो पाइप छोटा बन गया था कोलेस्ट्रॉल की वजह से वो अचानक से ब्लॉक हो गया और उस दिन उस जगह का खून का प्रवाह बंद हो गया और उसकी वजह से उसको हो गया इस्कीमिक स्ट्रोक. तो इस्कीमिक स्ट्रोक या तो कचरा वहीं के वहीं जमा होने से हो सकता है एथेरोथ्रोम्बोटिक या फिर एम्बोलिक, क्योंकि खून का प्रवाह जाता कहाँ से है ब्रेन को, हार्ट से जाता है. तो कभी कभी जिनको हार्ट के वाल्व की डिसऑर्डर होती है तो वहां पे नए ब्लड क्लॉट्स बनते हैं और वो खून की नलियों द्वारा ब्रेन में जाते हैं और ब्रेन की किसी खून की नली को ब्लॉक करते हैं. और कभी कभी कैरोटिड आर्टरी मतलब यहाँ से जो मेन आर्टरी होती है जो ब्रेन तक ब्लड लेके जाती है वहां पे थ्रोम्बस हो जाता है, वहां पे एथेरोस्क्लेरोसिस हो जाता है और एथेरोस्क्लेरोसिस के ऊपर थ्रोम्बस हो जाता है. इसको हम बोलते हैं कैरोटिड स्टेनोसिस. और हमको जब वो, क्योंकि सर्कल ऑफ विलिस है आगे ट्रैफिक सर्कल है, तो यहाँ पे जब थ्रोम्बोसिस शुरू होता है तो हार्ट के जैसा हमको चलने पे सांस वांस फूलना नहीं होता क्योंकि सर्कल ऑफ विलिस अपना काम निभा रहा है. मगर जब यहाँ पे अचानक एक दिन पूरा 100% ब्लॉक हो जाता है और वहां से कुछ टुकड़े निकल के आगे चले जाते हैं तो दैट इज कैरोटिड एम्बोलिज्म, आर्टरी टू आर्टरी एम्बोलिज्म, इनको बोलते हैं एम्बोलिक स्ट्रोक. तो पाइप में कचरा वहीं के वहीं फंस सकता है या कहीं से और से आ सकता है, दैट इज एम्बोलिक, या फिर पाइप फट सकता है, दैट इज हेमरेजिक स्ट्रोक. स्ट्रोक के बारे में लोगों को जानना क्यों जरूरी है. मैं जब एमडी कर रही थी, आई वाज डूइंग माय एमडी मेडिसिन इन 1993. एट दैट टाइम वी हैड अ वेरी निहिलिस्टिक अप्रोच टुवर्ड्स स्ट्रोक. इट इज नाउ कॉल्ड एज फिजिशियंस निहिलिज्म. निहिलिज्म मतलब अरे इसका कुछ नहीं हो सकता, ये सोचना. तो पढ़ाया ही इस तरह से जाता था कि स्ट्रोक में हम कुछ नहीं कर सकते, ब्रेन में एक बार ब्लॉकेज हो गया, ब्रेन एक बार डिस्ट्रॉय हो गया, उसका कुछ नहीं हो सकता. दैट वॉज द कॉन्सेप्ट एट दैट टाइम बिकॉज वी न्यू लिटिल. मगर अभी हमको ये समझता है कि ब्रेन के लिए बहुत कुछ किया जा सकता है बिकॉज ऑफ दिस कॉन्सेप्ट ऑफ न्यूरोप्लास्टिसिटी. मगर उसके भी पहले हम उस ब्लड क्लॉट को डिस्ट्रॉय कर सकते हैं, हम उस ब्लड क्लॉट को डिसॉल्व कर सकते हैं, मगर उसके लिए एक टाइम पीरियड है बिकॉज दैट हैज टू बी डन विद इन अ टाइम विंडो. इट इज नोन एज अ विंडो पीरियड. तो 4.5 घंटे के अंदर हमको वहां जाके उस ब्लड क्लॉट को डिसॉल्व करना पड़ता है. इट कैन बी डन थ्रू एन आईवी इंजेक्शन कॉल्ड एल्टिप्लेज. अभी नई दवाइयां भी आ रही है उसमें टेनेक्टेप्लेज भी यूज होता है, बट वी स्टिल यूज आरटीपीए बिकॉज दैट इज द मोस्ट रिकमेंडेड मोस्ट efficacious drug, and that is used within 4.5 hours given IV. मगर इंट्रा आर्टेरियली भी हम जा सकते हैं, ग्रॉइन से नली डाल के, जैसे एंजियोप्लास्टिक के लिए करते हैं वैसे हम ब्रेन के लिए भी कर सकते हैं. दैट इज डन बाय इंटरवेंशनल न्यूरो रेडियोलॉजिस्ट. और वो ग्रॉइन से नली डाल के ऐसे 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 वहां तक जाकर उस ब्लड क्लॉट को रिमूव भी कर सकते हैं, निकाल भी सकते हैं. दिस इज नोन एज मैकेनिकल थ्रोम्बेक्टमी. एंड इंट्रा आर्टेरियल थ्रोम्बोलाइसिस भी हम कर सकते हैं, वहां तक जाकर वो इंजेक्शन वक्त पर कब पहुंचेंगे, जब समाज में से ये निहिलिज्म चला जाएगा, जब समाज में से ये भावना चली जाएगी कि अरे लकवा आ गया, अब इसका तो कुछ नहीं कर सकते. Secondly, Dr. Archana is also going to tell you about it, that brain stroke is not just an attack of paralysis. I have had a patient whose wife brought him to me saying कि वो ये आज सुबह से अलग बिहेव कर रहे हैं, मुझे नहीं मालूम क्या है, मगर I thought a neurologist has to see him and he is behaving differently. This is not how he talks usually. This was years ago. I did his MRI. Unfortunately, 6 hours had already passed. She came to me in the afternoon. This had happened when he had woken up in the morning. And we found that brain के caudate nucleus नाम की एक area होती है, which is a deep seated nucleus in the brain. और वहां पर infarct हुआ था और उसकी वजह से brain stroke उसकी वजह से उनका behavior change हो गया. एक्स जूनियर एग्जीक्यूटिव नेहा, शी इज देयर इन द ऑडियो, मुझे कुछ नहीं हुआ है. हर फादर वाज सेइंग कि अरे नहीं नहीं ऐसी तो दिखती है, वो एक साइड पे सोई होंगी, बट शी हैड दिस वेरी स्ट्रांग गट फीलिंग, सो शी टुक हर टू द न्यूरोलॉजिस्ट इन नागपुर एंड दे डिड हर एमआरआई एंड शी हैड अ स्मॉल थैलेमिक इंफार्क्ट एंड इट वाज इंपॉर्टेंट टू आइडेंटिफाई इट बिकॉज दो शी कुड नॉट हैव बीन थ्रोम्बोलाइज्ड, क्योंकि ये सब समझने तक, उनको मनाने तक इतना टाइम चला गया था एंड कोविड टेस्ट वाज मैंडेटरी, सो ये सब करने में टाइम चला गया. मगर luckily the stroke size was very small and we could admit her, monitor her, so that within 7 days कभी कभी दूसरा stroke आ सकता है, वो prevent हो गया. So even if in a small stroke sometimes there can be a re-stroke within 24 hours, within 7 days, and that was definitely prevented in her. So कभी कभी visual symptoms होते हैं, जैसे मैंने कहा पीछे वाला जो दिमाग है वो पूरा का पूरा, because humans are visually driven humans, visually driven beings. हमारा सेंस ऑफ स्मेल बहुत पुअर है, मगर हमारा विजुअल कॉर्टेक्स बहुत बड़ा है. तो सिर्फ विजुअल कॉर्टेक्स में जब इन्फाक्ट होता है तो पेशेंट को एक साइड का दिखना बंद हो जाता है, और एक साइड का जब दिखना बंद होता है तो कभी कभी पेशेंट को ऐसी गलतफहमी हो जाती है कि मेरी ये आंख खराब हो गई क्योंकि मुझे इस साइड का नहीं दिख रहा है. पेशेंट पहले जाता है ऑफ्थेल्मोलॉजिस्ट के पास, मगर आंख तो नॉर्मल होती है, प्रॉब्लम कहाँ है, विजुअल कॉर्टेक्स में है. तो इसलिए क्या हो जाता है कि उनको वो ट्रीटमेंट मिस हो जाती है, क्योंकि उनको वो गलतफहमी होगी कि मुझे ये अचानक दिखना बंद हो गया तो प्रॉब्लम मेरी आंख में होगी, और इसमें टाइम चला जाने की वजह से अगर ऑफ्थेल्मोलॉजिस्ट को आइडेंटिफाई हो गया कि ये तो हेमी एनोपिया है, तभी वो न्यूरोलॉजिस्ट Sorry, today the connection at my place is a little flaky. So am I audible now again?
Yes, ma'am.
Yeah. So the की वर्ड इज अचानक. तो हमें समझता कैसे है कि ये ब्रेन स्ट्रोक है और ये पागल नहीं हुआ है, ये ब्रेन स्ट्रोक है, बिहेवियर चेंज इज बिकॉज ऑफ ब्रेन स्ट्रोक. द की वर्ड इज अचानक हो जाना. सो अचानक जब भी कुछ होता है, सो थिंक ऑफ इट दैट इज दिस ब्रेन स्ट्रोक एंड गो टू द नियरेस्ट इमरजेंसी डिपार्टमेंट. एंड बिकॉज इमीडिएटली न्यूरोलॉजिस्ट कहाँ है, कहाँ जाएंगे, समझना मुश्किल है, सो गो टू द नियरेस्ट इमरजेंसी डिपार्टमेंट एंड इन्फॉर्म देम कि ये जो भी हुआ है ये अचानक हुआ है, और तभी विद इन 4.5 आवर्स, क्योंकि 4.5 आवर्स ऐसे 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 निकल जाते हैं, क्योंकि लोगों को मालूम नहीं होता कि वो आरटीपीए इतना महंगा है, फिर तुरंत एमआरआई करना पड़ेगा, तो ये सब समझाने में ही हमारा आधा घंटा जाता है। और इसीलिए हम ये एडवोकेसी प्रोग्राम ले रहे हैं कि ये सब घर में किसी को होने से पहले ही अगर हमको मालूम हो, मुझे होने से पहले ही मुझे अगर मालूम हो, मैंने मेरे बेटे के साथ डिस्कस करके रखा हो, मेरी बहन के साथ डिस्कस करके रखा हो, तभी वो लोग मेरे लिए ये सब कर पाएंगे टाइम में। एंड न्यूरोप्लास्टिसिटी इज अ ब्यूटिफुल कॉन्सेप्ट। न्यूरोप्लास्टिसिटी मतलब ब्रेन की बदलने की क्षमता। ब्रेन बदल सकता है, हर पल बदलने की कोई उम्र नहीं होती, और मगर वो बदलने के लिए हमें मेहनत लेनी पड़ती है, एंड वी हैव टू टेक एफर्ट्स फॉर द ब्रेन टू बी एबल टू। अगर मुझे मेरे स्वभाव की कोई चीज बदलनी है तो मुझे मेहनत लेनी पड़ेगी। हम जब बच्चे as babies we are born, we are doing potty and susu in our nappies, मगर वो हम क्यों चेंज हो सकते हैं? why are we able to learn कि टॉयलेट ट्रेनिंग क्यों हो सकता है? because the brain learns to control the bladder center, the brain learns to control the potty center। तो ये जो बदलाव हमारे ब्रेन में होते हैं, फिर बच्चे स्कूल में जाते हैं, फिर बच्चे बोलना सीखते हैं, घर पे मम्मी पापा की बातें सुन के वो बोलना सीखते हैं। तो क्यों सीखते हैं? वो ब्रेन सब एब्जॉर्ब कर रहा है और ब्रेन की सेल्स में नेटवर्क्स बन रहे हैं। तो ये नए नेटवर्क्स बनने की जो क्रिया है, और हमारी जरूरत के हिसाब से वो नेटवर्क्स या तो ऐसे बनेंगे या ऐसे बनेंगे या ऐसे बनेंगे, ये जो हर एक के ब्रेन में अलग अलग तरीके से होता है, ये बदलाव न्यूरोप्लास्टिसिटी की वजह से होता है। और इस न्यूरोप्लास्टिसिटी की कॉन्सेप्ट्स जब हमारी बनने लगी, तभी न्यूरो रिहैबिलिटेशन और लैंग्वेज थेरेपी पे काम होने लगा। सो द नेक्स्ट टू स्पीकर्स हु आर गोइंग टू टॉक टू अस एंड शेयर देयर वर्क एंड देयर एक्सपीरियंस एंड देयर थॉट्स विद अस, these are the people who exploit neuroplasticity concepts to make the person improve from the deficit that has happened because of a brain stroke. So having said this, I will stop here. Brain stroke के बारे में मैं दिन भर बात कर सकती हूँ. It is a very favorite topic of mine, especially rehabilitation. Rehabilitation सिर्फ हाथ पैर का नहीं होता, भाषा का भी होता है, सोच का भी होता है, और उसी के बारे में हमारे आगे के दोनों स्पीकर्स बात करेंगे। थैंक यू फॉर योर पेशेंट लिसनिंग। आपके जो भी सवाल हो वो चैट बॉक्स में या व्हाट्सएप ग्रुप पे आप डाल सकते हो, ताकि हम नेक्स्ट आवर में उनके जवाब दे सके। थैंक यू सो मच एंड बैक टू यू शुभश्री।
Thank you so much, ma'am, for telling us how beautifully the brain works, also about what are the types of strokes and how to identify it, and telling us the importance about awareness of brain stroke. Now, I would like to call our next speaker, Mrs. Archana Ranade, ma'am. She is Masters of Neurophysiotherapy from GS Medical College, Mumbai. Director of Team Physiotherapy Services and Neurophysiotherapy Consultant at Dinanath Mangeshkar Hospital. She have been working with all kind of neurological cases for last 13 years with special interest in stroke and vestibular rehabilitation. She started Team Physiotherapy Services in 2007 as a way to take latest research and techniques to needy patients. Since then, she has focused on ensuring all the latest developments are implemented and knowledge is shared widely as possible across all stockholders like patient, caregivers, therapists, and administrator. Today, she runs two independent clinics along with the team of 15 qualified physiotherapists. Thank you, ma'am. Now, I would like a speaker to speak about the types of strokes and enlighten us about the awareness. Ma'am, over to you.
Thank you so much, Shubhashri. Good evening to all, and thank you, Purnima ma'am, to give me an opportunity to talk about rehabilitation in stroke, which is one of my favorite topics too. Just wanted to ask if you can see my screen. Is it visible to all?
We can see your screen, but not the presentation.
Oh, uh,
A rectangle is visible, which is gray in color. You can probably. Uh,
Now is it visible, ma'am?
No, we can still see the desktop.
Oh,
I think you can take the presentation on the desktop and
yeah, actually it is on the desktop. I will do it once
uh,
again maybe.
yeah, yeah.
Is it
Yes, yes. Now it
visible?
is perfect. Yeah, correct.
Uh, yeah. Hello, I am Archana Ranade. I am a neurophysiotherapist practicing in the field of neurophysiotherapy for last 12 years, and one of the favorite topics is definitely treating a stroke patient. As Purnima ma'am has already told us a lot about how does stroke happen, and about neuroplasticity, upon which the whole of neuro rehabilitation is based. Uh, Neuroplasticity के कारण ही we can change a patient from what the patient has suffered to him or her being a little better and start living his own life independently. I will just brush upon a few things. Purnima has already spoken about these things, uh, but we'll just go through it once again. Uh, Okay. So as she rightly mentioned, it is a brain attack, and the one thing is the blood supply to the brain is cut off, and there are neurons which starts dying. But one unfortunate thing is we don't experience any pain because there are no pain receptors in the brain. Incidence, if you go to see, stroke is like the second cause of deaths in many countries, and uh, even in our country, stroke is really increasing day by day, and so we should get aware about it, and we should have the immediate we should take our patients immediately to the hospital, to a bigger hospital, so that they get correct care. uh, I should not go into the details of causes of stroke, but yes, because of the hardening of the arteries, because of atherosclerosis, because of clot formation, or because of high blood pressure, that can be damage to the arteries, because of which the cells in the brain die, and we get a stroke, or the movements stop. So this is a small picturization of damage in artery. What are the common problems? As a physiotherapist, we usually help people with these problems. They are mainly weakness or paralysis on one side of the body. It is usually on the opposite side of the body, uh, onto which the brain has been affected. अगर आप यहाँ देखें तो अगर एक साइड का ब्रेन में स्ट्रोक हो गया है तो opposite side of the body gets affected usually. There is lack of balance, and many people have difficulty in swallowing and speech, which my colleague Sonal will definitely tell you about. There are other common problems there. There is extreme tiredness, there is difficulty sleeping, there is problems with speaking, understanding well, reading, writing. Now all this again depends on which part of the brain is affected. One more common symptom is numbness, weakness, or paralysis of the half side of the face, the lower half of the face. There is slurred speech, there is loss of vision also. There can be confusion, and there can be a severe headache. As Purnima ma'am had mentioned to you about vision problem, this is something which a hemianopia, that is vision problem after stroke, can see. If we see a full picture, these guys can see only half of the picture, and that is because half of the vision is affected because of stroke. So, if you come across patients who don't look on to their affected part after stroke, it is not that they are always ignoring it. It may be that they can't see on that side of the stroke. uh, there can be clumsiness, odd behavior, as she also gave us an example of a patient. So again, stroke हो गया किंवा whatever stroke झाला म्हणजे आपल्याला आता चालताच येत नाही, आपला हात वापरताच येत नाही असं नाही. माइल्ड स्ट्रोक्स असतात, or strokes in few different parts of the brain can just give you clumsiness of your behavior. Those patients are not diagnosed very early, and you just see their odd behaviors for a few days, after which the stroke may increase. So these things also may be there. Loss of sensation on one side of the body. This is also a very, very important thing. Many a times we come across patients who can still move. Their strength is okay, but their sensations of the half of the body is gone because of stroke. Now that causes a big deal of a problem, because whatever we move in our life is all because of the sensory inputs we get from the environment and from our uh, skin, our body receptors, our eyes and ears and all those things. So until and unless we feel something, we cannot move. So these patients of our who have good strength but they don't have sensation also cannot function well, and they need to be rehabilitated properly. The other problems which can come after stroke is they have problems with thinking, learning, memory, making decision. All this again is related to a specific part of the brain which gets affected post stroke. There are a lot of mood swings with our patients. There is depression, there is sadness, anger is there, anxiety is there. All these things are there pathologically. uh, I just want to tell you all, whoever are caregivers, at this moment you're listening to me, is it is not always की हे असेच वागतात किंवा हे आधीपासून असेच आहेत. वी ऑल शुड अंडरस्टँड की स्ट्रोक झाल्यामुळे त्यांना हा त्रास आता झालाय आणि तो आतनं त्रास होतोय. ते मुद्दाम असं करत नाहीये, ते मुद्दाम डिप्रेशनमध्ये गेले नाहीये. स्ट्रोक झाल्यामुळे त्यांना प्रॉब्लेम झालेला आहे. अँड हे जर आपण लक्षात ठेवलं तर वी डोंट स्टार्ट द ब्लेम गेम ऑन इच अदर. The next thing is, again, this has also been shown by Purnima ma'am, but I just wanted we all to revise ki our areas in our brain are differently placed, and depending on where the stroke is, that particular control will go or it will reduce. So as we all know, the hand control area is very big. She's shown you the thumb region, and that is why maybe the hand doesn't come up very well easily in all our patients. And that is our main aim, rather, because yes, leg control can come at least partially so that we can get the patient to walk. Arm control can come, but when it comes to hand, it is very difficult because it needs lot of practice, lot of concentration, and lot of inputs from the patient, from the therapist to uh, to recover and the hand to function again. As sorry. We also have seen that there are two hemispheres. One is the left hemisphere, one is the right hemisphere. Now these have their own controls, these have their own tasks. Our God has given brain various different tasks. So it again depends which side of the brain is affected. And that really matters in rehab, because whenever it's the left brain, you usually start ignoring things, and you cannot do maths, you cannot take good decisions. When it is a right hemisphere, you don't understand the spatial context, you don't understand ki, where am I placed at that particular moment. पेशेंट को ये नहीं समझता कभी कभी कि वो बेड के ऊपर है कि नीचे है, पंखा ऊपर है पंखा नीचे है, मुझे आगे चलना है, अगर एक स्टेप है तो वो स्टेप से कितना नीचे, डेप्थ कितना है वो स्टेप का नीचे उतरने के लिए, और इसीलिए फिर रिहैब में प्रॉब्लम होता है, फिर वो चलने में डरते हैं एंड गिरना भी हो सकता है. सो ऑल दिस इज governed by our right brain, so that is also very important. Depression भी सबसे ज्यादा एक साइड ऑफ द ब्रेन, इफ देयर इज लेफ्ट साइड ऑफ द ब्रेन अफेक्ट हुआ है तो डिप्रेशन ज्यादा दिखता है हमें. Okay, so how do we move? Sorry, how do we move? Our main movement is through muscles, and muscles get signals through nerve. Nerve is stimulated by the spinal cord, but the spinal cord receives signals from the brain. So you need to rehabilitate your muscles. Muscles यानी हमारे स्नायु है. हम जब खाना खाते हैं तो हम स्नायु का इस्तेमाल करके हाथ मुंह तक लाते हैं, लेकिन उसको, वो स्नायु को उस तरीके से हिलने के लिए हमारे नर्व्स इम्पॉर्टेंट है, और नर्व्स को मैनेज करता है हमारा ब्रेन. इसीलिए जब भी हम पोस्ट स्ट्रोक किसी पेशेंट को एक्सरसाइज के लिए शुरू करते हैं, हमको ये ध्यान रखना चाहिए कि वी आर ट्रीटिंग मसल्स बट वी आर making changes in the brain. Rather, we all should understand that we should try to make changes in the brain. Then only will the muscles get their own memory of movement. तो सिर्फ जाके many a times we keep on moving the patient ourselves. हम खुद से पेशेंट को हिलाते हैं, उसका पैर हिलाते हैं, हाथ हिलाते हैं, उसको खड़ा करते हैं 4-4 लोग और चलाते हैं, लेकिन इससे फायदा नहीं है क्योंकि हम बाहर से वो पेशेंट को हिला रहे हैं लेकिन पेशेंट खुद से कुछ कर नहीं रहा है, वो खुद का ब्रेन यूज नहीं कर रहा है. सो वी एज थेरेपिस्ट एंड केयर गिवर्स should teach the patient to understand the movement and make him move, try to move by himself. We have to give him support, जिसकी वजह से वो there will be neuroplasticity and the muscles will get better and the movement will get better. Muscles have to be gotten better with exercises. So with each small movement, there is an activation of particular area of our brain that is which is responsible for that particular action. When I move my arm from the shoulder, the neurons which are firing are different from when I move my elbow or my hand. So हाताचे व्यायाम केले म्हणजे पूर्ण झाले का नाही, प्रत्येक मुवमेंटला वेगळे न्यूरॉन्स आहेत आणि त्याच्यासाठी आपल्याला प्रत्येक मुवमेंटची प्रॅक्टिस करून घेणं गरजेचं आहे आपल्या पेशंटकडनं. So again, as we all know, time is brain, and there should be an emergent evaluation because every minute, if we make delay in our patient to get treatment from our neurologist, we are going to lose a lot many neurons. So coming to stroke rehabilitation, what are the main principles is start early. You have to start early from the ICU level. ICU मध्ये many at times patients and relatives will say की आता पेशंट ला काही कळत नाहीये और पेशंट हालचालच करू शकत नाहीये. नाही, पण त्या क्षणाला जर आपण बेसिक एक्सरसाइज सुरू केलं तर मेनली त्यांचा प्रॉब्लेम जो टाइटनेस येतो, स्पॅस्टिसिटी येते, कडकपणा येतो, तो कमी होईल किंवा तो नाही येणार इफ वी स्टार्ट करेक्ट थेरपी फ्रॉम द ICU level. In the ICU, even if our hand and the leg is not moving, we should start working on our trunk. आपल्या शरीर धडावर काम करायला खूप गरजेचं असतं त्या क्षणाला बिकॉज दॅट इज नॉट कम्प्लिटली अफेक्टेड. त्याचा अर्धा भाग चालू आहे आणि म्हणून आपण त्याच्या मदतीने वी कॅन मेक द पेशंट मूव्ह, लाईक वी कॅन मेक द पेशंट टर्न, वी कॅन मेक द पेशंट सिट. ह्या गोष्टी जरी आपण ICU लेवलमध्ये सुरू केल्या तरी इट विल हेल्प अ लॉट इन लॉंग टर्म रिहॅबिलिटेशन. Active participation is definitely mandatory. So till the time the patient doesn't understand everything, it is okay for us to just tell him a very few things, like you have to turn on your left side, this is your left side, this is your right side. We can show him a mirror in the ICU or in the wards and just make him understand, make him aware. कारण when it is a brain stroke, the neurons आपले मेलेले असतात, याचा अर्थ ती मुवमेंट, ते मसल मेमरी डिलीट झालेली आहे. तर ती डिलीट झालेली मसल मेमरी और मसल्स और द बॉडी पार्ट विल कम बॅक वेन वी शो देम अ मिरर. आपण त्यांना मिरर दाखवू शकतो की यू आर अ कम्प्लीट ह्युमन बीइंग. आत्ता आपला लेफ्ट साईड हलत नाही, तर तो हलवण्यासाठी आपल्याला लेफ्ट साईडची जाणीव करून देण्यासाठी आपल्या डोळ्यांचा वापर आपण करू शकतो. And there is a definitely it is a tailor made thing for all strokes because as every human being is different, each and every stroke is also different.
Can you just click on that yellow thing and slide it away, then it will go.
It is actually it is not going, ma'am. मी दोनदा click केलं.
Okay. Now it's become fainter.
It is just fading away and then coming back.
Okay.
It is okay. Shall I move ahead?
Yes, go ahead.
Yeah. Okay. So these are a few pictures which will show you a rehab department in general where there are parallel bars, there are steppers, there is a ball with a bed. You may see all these pictures in a rehab department wherein you will need all this space and a bed for the patient to lie down and do exercise, sit and do exercise. This picture of stimulator is also shown here just for thing is मेनी पीपल बिलीव्ह की करंट दिल्याने सुरू होतं का काम करायला. नाही, करंट गरजेचा असतो, पण करंटनी किमान आपल्याला तो हात कसा हलेल याची जाणीव होते. सो इट इज अन अडजंक्ट टू ट्रीटमेंट. फक्त करंट देऊन आपण पेशंटचं हालचाली सुरू नाही करू शकत. One more thing is, before making the patient to start walk or start use his or her hand, you should understand ki until and unless the muscles involved achieve their not normal but at least near normal strength, they will not be able to do that activity. माझ्या पायातल्या स्नायूंची ताकद आली तरच मी चालू शकणार आहे. नुसतं चालवून 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 तो चालणार आहे का? नाही चालणार आहे. तुम्हाला पायातल्या स्पेसिफिक मसल्सची ताकद हवी. ती ताकद आली की तो पेशंट आपण चालायला शिकवलं की चालणार आहे. सो स्ट्रेंथ ट्रेनिंग आपल्याला खूप गरजेचं आहे, अँड दॅट रिक्वायर्स इमेन्स रेपिटेशन and dedication from the patient, from the relatives, and from the therapist. Then comes the functional training. Speech is definitely very important, which Sonal will tell us all in details. And vocational training is for a few patients who may not go back to their normal ability as or prior life, but they need something different to start their new life. Yeah, so basically we need to rehabilitate patient for how long. So that is one question which is asked by all the patients. Abroad usually they give they have made time slots ki, for first 3 months it's acute, then 3 to 6 months it's subacute, and then chronic. So subacute phase झाल्यावर maybe the patient has to live with whatever neuro deficit the patient has. But in our experience, we have seen that patient or neuroplasticity is definitely comes whenever you start working with the patient. May it be post 6 months, post 1 year, post 10 years also. But at some point of time, you should accept looking at the amount of stroke and the amount of pre-morbid status and the amount of input from the patient, where you can maybe stop the rehab and start your normal life. Or the patient's relatives and caregivers should learn what is the most important thing for our patient and keep on continuing with that. Factors responsible for complete rehabilitation, as I said, is definitely it's the amount of injury, and it is the severity, it is the medical management, which Dr. Purnima has already told us in details. uh, I should definitely mention it here. I also mentioned it to Dr. Purnima the other day that pre-COVID or pre-lockdown phase, we for the last 6 to 10 months, or whatever, 1 year, we were seeing very less severe strokes, severe cases of strokes, because the people around are getting aware maybe, and they're bringing their patients immediately to the hospital, and our doctors can save the brain if the patients are gotten in time. But again, in COVID, maybe because of the coronavirus, we are seeing a lot of neurodeficits, and the paralysis is of more intensity. So medical management is very important. Physiotherapy treatment, correct physiotherapy treatment, and uh, again, the input from the patient is also very, very important, and that's why it's highlighted as patient effort. I always tell my patients that physiotherapy is not medicine wherein we give you pills and you eat it and you'll get better. It has to come from within. तुम्हाला जर इच्छा असेल तर तुम्ही नक्की बरे व्हाल, कारण तुम्हाला त्याचं काम करायचंय. कोणी बाहेर न येऊन तुम्हाला हातपाय हलवले तर तुम्ही नाही तुमचे स्नायू बरे होणार. The aim of neuro rehab is again the same thing, to get back your original activities, maximize your functional independence. फंक्शन तुम्ही उठून तुमचे चालायला लागलं पाहिजे. ऍटलिस्ट घरातल्या घरात एका हाताने का होईना काम केलं पाहिजे. दुसऱ्या हाताची मदत आपण दुसरा हात आणतच आहोत. लॉंग टर्म डिसेबिलिटी ज्याला म्हणतो, की लॉंग टर्म तुम्ही व्हीलचेअरवर आहात किंवा कोणाच्या तरी डिपेंडेंट आहात, ती कमीत कमी करण्याचा आपण प्रयत्न केला पाहिजे. But you should also remember that rehab or neuro rehab is not a magic therapy. It is a long standing and takes a lot of effort of the patient, of the therapist, and of the caregivers. How can a family help? Again, we all should know as family members that saying is very easy, guys. I know I've seen a lot of patients and their relatives, they get completely distressed, and they are ते संपतात when one of the family members or the earning members get a stroke. But try to be patient. You have to learn practical measures of helping our patient. And one thing is acceptance. Again, this is very easier said than done, but accepting that now my husband or my wife has gotten a stroke and he or she may take longer time. I'm talking about big strokes or big infarcts, and they may take time to get back to their feet. That will help you to understand how much your input should be. सुरुवातीला all the family members are very on their feet की मी कसंही करून मी सगळं सोडीन आणि मी माझ्या नातेवाईकाची मदत करणार. पण जसा जसा टाइम जातो आणि आपल्याला कळतं की नाही इट इज गोइंग टू टेक अ लॉट ऑफ टाइम, तेव्हा मग दे गेट डिप्रेस्ड आणि त्यांची तब्येत बिघडू शकते. सो ऑल दीज थिंग्स हॅव टू बी taken care of. You should understand, you should question the doctor, you should question your therapist, and you should get involved in the treatment. I wanted to just highlight some myths which were there regarding stroke, which are also there. One is you cannot prevent a stroke, but in the first video itself, I was so glad to see that video. Very nicely done. Stroke is largely preventable. A stroke cannot be treated. No, it requires medical emergency treatment, but it can be very well treated. Only elderly have strokes. Not at all. Ma'am also mentioned she saw a 20-year-old stroke in lockdown period, and I've been seeing young strokes for so long that it feels like, oh my god, आता म्हणजे 35 वर्षाचा मुलगा आहे आणि त्याला आता स्ट्रोक झालाय, तो काय करणार आहे. बट अगेन यू हॅव टू बी aware. Even if you're aware, it helps you. Strokes are rare, not at all. Strokes are very very common. मला काही होणार नाही, मला आय एम सो हेल्दी, मला स्ट्रोक कधीच होऊ शकत नाही असं कोणीच म्हणू नये. रादर recovery from stroke occurs in first 6 months only. Again, not at all. We have seen, we are treating our patients, and it definitely depends upon the quantity and the quality of therapy. And only if the muscles go into contracture, the muscles are completely tightened, we may not be able to do anything for that particular muscle. So for that not to happen, it is our responsibility, it is the caregiver's responsibility to see that in the acute period you have to keep all the muscles into their lengthened position. Stroke does not run in family, it does run in family. A few of the examples show us that. And if stroke symptoms pass, you do not need to seek treatment. Not at all, again, because these are transient ischemic attacks, small clots which may come and go, but that may lead to a bigger stroke. So, if you have gotten any little problem like slurred speech, just today in the morning, one of my stroke patients who is taking treatment with us, she is almost rehabilitated. She got some tingling in her two fingers. She called me saying, what should I do? I said, just check your BP. Her BP was very high and she's gotten admitted to the hospital now. So she has saved her next stroke maybe. So you have to be very much aware, and you should seek treatment even if there is little problem you feel that something has come. Oil massage will improve stroke victims. No recovery can be expected with massage, and no recovery can be expected without active participation of the patient also. So we've been hearing की 6 महिने झाले फिजिओथेरपिस्ट घरी येऊन जातोय पण काही उपयोग नाही. पण फिजिओथेरपिस्टच काम करत असेल मे बी आणि पेशंट आपला काही करत नसेल तर यू विल नॉट गेट रिकव्हरी. फेथ हिलिंग, होमिओपॅथ, आयुर्वेद, कबुतराचं रक्त, so many things are there when it comes to rehab, but there has not been any studies, there has not been any evidence, or we cannot expect recovery from such things. If there's permission, I would just like to show you, this is a typical stroke walking which you can see, and these are little aids which we give them to walk. He is a very severe kind of a stroke, and yes, so this typical walking can be still further rehabilitated. But आता याच्यात प्रॉब्लेम काय, पायाचे मसल्स आहेत पण ते इतके चांगले नाहीत की तो माणूस चांगला चालू शकतो. मग त्याच्यासाठी ही नीड्स टू वर्क ऑन हिज लेग मसल्स. नाव लेग इज अटॅच टू युअर ट्रंक. तुमचे पाठी आणि पोटापासूनच पाय खाली येतोय ते मसल्स आहेत, तर यू हॅव टू वर्क दोज मसल्स, कारण ते पण वीक आहेतच. सो यू हॅव टू अंडरस्टँड दॅट इट इज नॉट वन पार्ट की माझा तुम्ही माझं पाऊल नीट करून द्या असं नसतं ते. इट इज ऑल टुगेदर वेन इट कम्स टू स्ट्रोक. दिस इज अ व्हिडिओ ऑफ अ सेन्सरी हँड. या माणसाच्या सगळे हँड मसल्स नॉर्मल आहेत, बट स्टील ही कॅनॉट पिकअप बिकॉज देर इज नो सेन्सेशन इन दॅट. सेन्सेशनच नाही. तुम्ही डोळे बंद करून एक एक दाणा उचलून बघा, कदाचित तुम्हाला तो उचलता येईल, कदाचित कशाला, कारण तुमच्या बोटांमध्ये सेन्सेशन आहे. पण आपले काही स्ट्रोक पेशंट्स असतात ज्यांच्यात ताकद राहते पण सेन्सेशन नाहीये. फॉर देम सेन्सरी रिहॅबिलिटेशन एक वेगळा पार्ट असतो, ज्याच्यामध्ये वी टीच देम हाऊ टू again learn the sensations, and they do learn. Similarly, this guy has good muscles in his, he's the same guy, has good muscles in his leg muscles, but त्याचं चढणं बघा कसं आहे. अगेन बिकॉज त्याला चढताना सारखं खाली बघावं लागतं की कुठली पायरी आपला पाऊल नीट पडतंय की नाही. पावलामध्ये प्रॉब्लेम आहे का? नाही, त्याच्या सेन्सेशन मध्ये प्रॉब्लेम आहे. This is something which I was talking about, acute care. या आजी आहेत, where we were teaching her only to roll. एका बाजूने दुसऱ्या बाजूला वळायचं. Rolling is important because when you roll you use your trunk, आणि ते वापरलं तर आपण बसू शकतो, बसलो तर आपण उभं राहू शकतो. सो सर्वात पहिले काय करायचं, तर we have to make our patients move from one side to the other by themselves. And this is a case in the ICU where we were just showing him a mirror. He is a case of pushers actually, wherein stroke एका बाजूला असतो, म्हणजे एका बाजूची पूर्ण साईड पॅरालाइज्ड आहे, पण बिकॉज ऑफ द प्रॉब्लेम इन अ पर्टिक्युलर एरिया इन द ब्रेन, दे कीप ऑन पुशिंग देमसेल्स टू द अफेक्टेड साईड, म्हणून ते बसूच शकत नाही. मग अशा लोकांना सारखं त्यांचं स्वतःचं पूर्ण शरीर दाखवून मिररमध्ये, किंवा गिव्हिंग देम अ डिफरंट ऑब्जेक्ट की सिमेट्री काय आहे, तुम्ही सरळ बसणे म्हणजे वॉट एव्हर सिमेट्री तुमच्या शरीराची कशी असते हे समजवून आणि त्या भागावर वजन घेऊन वी टीच देम टू सिट ऑन द नॉर्मल साइड. दीज गाईज कॅनॉट सिट ऑन द नॉर्मल साइड ऑल्सो. This is a lady who is almost better, but we are using sorry for the background noise, a small device which you can see here. This is known as FES. now हे छोटासा device है which will help you in moving your ankle in a proper manner, so that will give you a proper gait or proper walking. This is again being trained for her walking gait, or we use those shoes which you saw in the first video. And this I would like to just show you a patient who is completely normal now post stroke. He also had a complete hemiplegia, but he is now walking completely normal. He is using his hands also. So this is our normal walking. I just put this photograph to tell you all ki stroke is not always paralysis, as ma'am has definitely mentioned in her talk. It can be just not recognizing, not understanding. Not understanding मध्ये you have this apraxia thing where they don't त्यांना माहिती आहे की हा ब्रश आहे आणि हे टूथपेस्ट आहे, पण ते लावून दात घासायचे नाही कळत. दात घासायचं या दोघांनी, पण ते लावायचं कसं ते नाही कळत. सो दॅट इज अप्रॅक्झिया विच दिस पेशंट ऑफ आर्स वसंत नावडकर म्हणून पहिल्या दिवशी जेव्हा ते आले होते, वी आस्क्ड हिम टू राईट हिज नेम अँड ही हॅज रिटन इट लाईक दिस. ही वॉज टेलिंग हिज नेम प्रॉपरली. ते बँकेत जाऊन कामं पण करायचे त्यांची, पण त्यांना लिहिताच यायचं नाही, कारण तेच कळायचं नाही की कसं लिहायचं. And then post 6 weeks of rehab, he could write his name properly. So this is also kind of stroke which can be rehabilitated with correct treatment. Again, as ma'am said, there is so many things to talk about stroke and share with all of you all. We can take the questions after Sonal's talk, but I think I can stop here now. Thank you.
Thank you so much, ma'am, for guiding us and discussing, telling us about the symptoms, the common problems faced by the patient, what are the damages to the brain, what the treatment is given in rehab, this devices used in rehab. Thank you so much. Now I would like to call our next speaker, Ms. Sonal Chitnis, ma'am. She is an assistant professor at Bharatiya Vidyapeeth University, Medical College School of Audiology and Speech Language Pathology. She is specialized in bilingualism, neurocognitive communication disorders, mainly in stroke, dementia, epilepsy, neurorehabilitation. She is consultant neuro-speech language pathologist at Dinanath Mangeshkar Hospital, Pune. She coordinates the website FSCR Stroke Association of India under the guidance of her mentor, Professor Subhash Bhatnagar. They have initiated stroke aphasia awareness campaign. Each one teach one and reach one. Stroke can happen to one in four. Miss Chitnis is also task force member of Indian Federation of Neurorehabilitation and Indian Academy of Neurology Physiology expert group. She has been active advocate for brain health, stroke, early intervention, cognitive communication, safe swallowing. She had received Young Investigator Award at WSO 2016 for paper on brainstem stroke and recipient of IAN Travel Grant Fellowship in Cognitive Neuroscience. She aims to make many advocates who can help Indian population with the help of Niche Foundation, ISHA, IAN, IFNR, WFNR. Ma'am, welcome. Over to you.
Thank you, Shubhashri. Thank you, Purnima ma'am and entire Niche team for giving me an opportunity to talk here regarding my passion, neuroscience of language, cognition, aphasia. So what is stroke and aphasia? Let me share my screen. Is my screen visible?
Yes, it is visible.
So what is stroke? Aphasia. I would like to talk to you more extempo about the aphasia assessment and the recovery than much in the slides. So I don't think so I would use much of my slides. So मैं आपसे कभी हिंदी और कभी इंग्लिश में बात करूंगी. So what is stroke? You all have seen that. In the brain, brain is a highly perfused organ. We need lot of oxygenated blood supply and a glucose supply to the brain in order to function well. So what we speak, we think, what we write, what we read, how do we calculate, all this comes into the verbal cognition and communication, the way I think, the way I want to speak, put my thoughts across. When someone is asking me something, when I'm going to answer accordingly, when I'm reading a beautiful poem with a proper intonation, melody, stress, when I'm thinking and arguing on some point and putting my points across, when I'm thinking and naming, labeling, all this requires your language abilities and hence the communication happens. And when the person gets a stroke, that means that certain part of brain does not receive a proper blood supply. You have already heard that we have ischemic stroke and hemorrhagic stroke, different types of stroke. So जब किसी को लकवा मार जाता है, मतलब अगर शरीर के ब्रेन में दो हेमिस्फेयर होते हैं, राइट और लेफ्ट, तो मैं राइट हैंडेड हूं और मेरी बातें, मेरा समझना, बोलना, लिखना, ये मेरे लेफ्ट ब्रेन में है. So I am right handed. Majority of times, almost 85 to 90% of time, a right handed person will have language and verbal cognition in the left brain. And when the brain gets hemorrhage or ischemic hemispheric stroke, that means either he can't understand, or he can't speak, or he can't read, or he can't write, or he can't calculate. He may not be able to sing and type also legibly. All these are mild, moderate, or severity wise, different part of these modalities will get affected in aphasia. And that is how the stroke aphasia happens. उसे हम बोलते हैं वाचाघात. Aphasia मतलब वाचाघात, loss of speech, loss of language. And then the person may not be able to understand or may not be able to speak correctly. So planning, programming, and execution. I call it PPE. In this post-COVID era, we all know that we have to gear ourselves. So the talk today is helping you understand what is stroke, what is the aphasia, and what is a neurorehabilitation. So without thinking that, oh, I don't need to know about stroke, why should I feel that we are all aging, and stroke can happen to anyone. Pediatric stroke patients also are there who require speech, language, cognitive, physical therapy. Now, why young population also gets stroke? Purnima already has told you that stroke can happen to anyone, but more in adult patients where the hypertension, then the diabetes, stress, anxiety, and a poor lifestyle can lead to the stroke. And if the stroke happens to the left brain, which is your talking brain, then aphasia can happen. The person may not be able to walk and also talk. Sometimes we get to see patients who have recovered very well with the hand function and the leg function. They started walking very early, but from the ICU, when the patient has got a stroke, to the person who has come to the general ward or a private ward, or he's discharged to the home with able to come on his own, walk on his own, brush on his own, dress on his own, but still can't talk, still can't read, still can't write. And if that is there, you cannot assume that it will come on its own. It requires a proper rehabilitation. So when we have seen the brain stroke can happen to the person who has a talking brain, left brain affected. And it is important to understand that what is stroke, what is aphasia, what modality is more affected. Is it talking, understanding, reading, writing, or all these affected? So in right hemisphere, it's very rare. However, one should understand that we get to see people who are right-handed and they do get aphasia, that's a crossed aphasia. जब किसी को स्ट्रोक आता है राइट हैंडेड बंदे को, अगर लेफ्ट साइड में बात होने से, तो लेफ्ट हेमिस्फेरिक स्ट्रोक, लकवा, बात करने का वाचाघात प्रोड्यूस करता है. लेकिन अगर राइट हैंडेड पर्सन को, इंडिविजुअल को, व्यक्ति को लेफ्ट नहीं राइट हेमिस्फीयर में स्ट्रोक आता है, अगर बात करनी नहीं आ रही है, बोलना नहीं हो रहा है, फ्लुएंट बात करनी नहीं आ रही है, तब ही उसे क्रॉस्ड अफेजिया बोलते हैं. और हमें समझना चाहिए कि अफेजिया की अलग अलग टाइप्स होते हैं. ग्लोबल मतलब ना वो बात कर पाता है, ना वो समझ पाता है, ना वो ठीक से लिख पाता है. और अगर बंदा सीखा हुआ हो, पढ़ा लिखा हो, एक नहीं, दो, तीन, चार बातें, भाषा बोल पाता है. हम सब बाइलिंगुअल है. So let me tell you about bilingual aphasia. People who speak more than 2 languages, they do read or write more than 2 languages, they are biliterates. So we all are here bilinguals. Like I speak Marathi, Hindi, English, Telugu. So it's important that I have to be called multilingual. Now, when it happens that brain gets stroke, aphasia, person may have equal impairment of language in all these languages he or she speaks, reads, writes. And what happens that the person cannot understand and he can't process what is asked. So when you speak to the person, आप जब पूछेंगे कि आपका नाम बताओ, आपने कुछ खाया है, आपको कुछ चाहिए, so if you speak faster, he has difficulty understanding, he can't process. Obviously, he might give a non-fluent, gibberish, or a complete fragmented speech, which will be difficult for you to understand as a layman. Now, at some point, families don't understand how to speak with a person with aphasia. At the same time, person's job, if he or she is a teacher or accountant or an engineer or a doctor or previously a security guard or a farmer, so each of the occupation he or she was earlier playing a role gets affected when you can't communicate well. So aphasia happens to all the people with stroke who have language networks in the brain affected, and those patients require aphasia has aphasia post stroke. So what will you do? You can ask the person to name. Moment someone has a stroke, so ask him to speak, ask him to count 1 to 10, ask him to count 10 to 1, ask him to repeat simple words, one simple sentence, ask the person to read a simple sentence and write the same. Check if he or she is unable to do that. That means his language and communication is affected. Also, ask the person with aphasia or a stroke to sing a song, whether he is able to sing, whether he is able to say correct bhajan or a national anthem. Check that how is his prosody. Check that how is his right hemisphere function, left hemisphere function in very, very nutshell, simple words. Now, you say, am I doctor? Why should I know the brain function? Yes, you all speak. Yes. Does it write? Yes. And how? Which part of brain is important for that? So you have already seen this and heard this from Punya ma'am and also Archana ma'am. So let me go ahead with aphasia and communication. So it is a language loss, communicative loss. So in brain, you have certain parts which will help you read, write, talk, calculate. So once you screen the person has aphasia, make sure he gets as early as possible speech, language, cognitive communication therapy. So it is important that you get the person right treatment. The person with aphasia is not deaf and dumb. If he cannot understand what you speak and he makes a wrong comment or he does not understand and speaks gibberish fluent utterance, that's a sensory aphasia. So you have two aphasias to understand. Broca, which is a motor aphasia, where person understands simple commands but cannot speak fluently. Other aphasia is a sensory aphasia, where you understand almost nil or nothing spoken, but you speak go you continuously, and the patients will sound very gibberish. So the sensory aphasia means patient is fluent, they are sometimes happy-go-lucky, they don't understand, and family can laugh at them, the caregivers don't understand how to behave, how to take them, and the person is taken as a psychotic at a times. I have seen some patients going to psychiatrist where they require neurology and speech language therapy. So it is important that post stroke, what is the brain area affected, and is he or she has aphasia, is fluent or non-fluent. So the person with aphasia is important, his aphasia is not important. The person is important to be treated. He needs he deserves a respect, he deserves intervention management, and with just medication aphasia does not recover. You have to have pharmacological and behavioral intervention importantly given. So let's see recovery in aphasia. Does speech language therapy, communication therapy help? Yes, definitely. Speech language therapy only helps in aphasia. You have to help the person with aphasia communicate effectively. So global aphasia patients who cannot understand, speak, read, write in a month or 2 or 4 or 6 months, they evolve into the motor aphasia. That means they will understand slowly, but they may not speak fluently. Now, few aphasic patients who are fluent at the presentation, but they don't understand well. So there's sensory aphasia. That means sensory ability to understand is affected, but to speak, produce a speech fluently is not affected. So this Wernicke's aphasia will go into kind of transcortical aphasia. That means what? They will repeat after you correctly. You say, आपका नाम क्या है? वो बोलेंगे आपका नाम. शायद ज्यादा बोल जाएंगे, ले किताब है, नाम ना किसी व्यक्ति का नहीं ले पाते. So global aphasia and Broca's aphasia are motor aphasias, non-fluent. Wernicke's aphasia is the fluent aphasia, a sensory aphasia. Each aphasia type is evolving into different picture. Now, this is technical jargon for you. Let me make it simple. जो व्यक्ति बोल नहीं पाता है, समझ नहीं पाता है, लिख नहीं पाता है, वो 1 महीने में, 2 महीने में, 3 महीने में, कभी कभी 6 महीने तक धीरे धीरे इम्प्रूव हो रहता है. लेकिन थेरेपी देने से इम्प्रूवमेंट होती है. कभी कभी थेरेपी न देने से इम्प्रूवमेंट थोड़ी सी हो जाती है, लेकिन फिर भी करेक्ट बोलना, समझना, लिखना नहीं आता है. सो स्पॉन्टेनियस करता है बोलने से, समझने के लिए, और घर वाले कोशिश करते हैं उनको कुछ चीजें बताने के लिए. तब क्या होता है कि प्लास्टिसिटी, जो ब्रेन अपने आप से डैमेज पार्ट के फंक्शन किसी और पुर्जे को दे देते हैं. सो हमारे पास 2 ब्रेन हेमिस्फीयर है, लेफ्ट एंड राइट. सो जहां पे स्ट्रोक आ गया है उसके बाजू का एरिया जो अच्छा है वो थेरेपी के बाद में या फिर अपने आप भी बोलने से, समझने से, प्रैक्टिस करने से, when by a efficient speech pathologist can really give a help to the person with aphasia. Sometimes when you cannot reach to a proper speech language therapist, to the hospital or the institutes, आप tele rehabilitation भी ले सकते हो. That means you can search who are the speech therapist, speech pathologist in your area or abroad or nearby states. Forget about abroad. In India itself, you have so many tele-rehabilitation, aphasia therapy giving people who are professionals, who are helping you understand the aphasia, क्या करना है, कैसे उनको हैंडल करना है. सो फोन पे, लैपटॉप पे भी आप थेरेपी ले सकते हो. सो ये रिकवरी कैसी होती है? नॉन फ्लुएंट व्यक्ति फ्लुएंट बनने के लिए उसे पहले हमें समझना पड़ता है कि उसे क्या दिक्कत है. बोलने में दिक्कत है, वर्ड लेवल पे है, सेंटेंस लेवल पे है, कौन सी चीजें ज्यादा बोल पाते हैं, कौन सी चीजें नहीं बोल पाते हैं. उसके बाद में क्या करना है आपको कि थेरेपी स्टार्ट होने के बाद में हमें घर पे भी कोशिश करनी कि उनसे कैसे बात करें. सो अफेजिया, इट मीन्स लॉस ऑफ स्पीच एंड कम्युनिकेशन. इट डज नॉट हैपन दैट इन अ वन सेशन पर्सन इम्प्रूव्स. सो स्लोली आपके अप्रोचेस, आपके टेक्निक्स, मेथड्स आप सीखोगे स्पीच थेरेपिस्ट से, और उसके बाद में आप उनसे पूछोगे कि घर पे क्या करवाना है, उनसे कैसे पूछे, उनसे कैसे बात करे. सो मॉर्निंग, आफ्टरनून, इवनिंग, यू शुड हैव ADL, एक्टिविटीज ऑफ डेली लिविंग कम्युनिकेशन, डूज एंड डोंट्स. कितने भाषा में बात करें? जो भाषा पेशेंट हमेशा बोलता है उसी में बात करो. डोंट स्विच टू इंग्लिश इजीली, डोंट स्विच टू डिफरेंट लैंग्वेजेस. पोस्ट स्ट्रोक bilingual patients who earlier were very proficient in reading, writing, talking, very intellectual person can have difficulty understanding in the second language. So stick to one language which is simpler for the patient while talking, but do talk to him in other language also if the person is comfortable. But at the same time, make sure you gain understanding of the person's bilingual aphasia and its treatment from your therapist. Don'ts of therapy: don't treat the person with aphasia as a deaf and dumb, mentally challenged. Don't treat the person that he is supposed to be given his time, put TV and don't talk to him. That's not good. You should communicate, you should help him, you should give him time, you should try the person with aphasia get optimum rehabilitation and practice with aphasia therapy apps available with telerehabilitation, computer assisted material, some printed worksheets you can get, and work on person speaking, understanding, reading, writing abilities. So intensive 12 hours per week rehabilitation is given as a practice standard. So we have to help the person steadily improve. Okay, so he can gain confidence to communicate and he goes back to the new normalcy post stroke aphasia. So you should give him a lot of communication cards you can have in your home. Place certain easy communication board for him to point and tell you that he wants to go to toilet, he wants to talk, he wants to make a call. He can point and show if he cannot talk. He can point and show if at all he wants something to be conveyed, or you are asking him, he's not understanding. You point him and show. So that becomes an easier way. Now, some part of brain important for your visual integration, if that is impaired, then small signs and small cards don't help. So make sure that the person understands with the at least good amount of cards which are usable, readable, understood by the patient. So you can have some communication cards, and that can help you communicate with the person with aphasia. So severe aphasia, moderate aphasia, and a milder aphasia, each of them will have a different requirement. Don't think that it will on its own improve. अपने आप से aphasia, वाचाघात improve नहीं होता है. 89 to 95% of patients don't improve on their own, but they require steady, regular, intensive rehab. इसका मतलब है rehabilitation आपको लेना है. फेस टू फेस इंडिविजुअल थेरेपी या ग्रुप थेरेपी इन अफेजिया हेल्प करती है, जहां पे 5-6 अफेजिया पेशेंट्स इकट्ठे होते हैं, उनके घर वाले इकट्ठे होते हैं और बातें करते हैं, गाने गाते हैं, अपनी दिक्कतें बातें करते हैं, शेयर करते हैं, और फिर वहां पे भी स्पीच लैंग्वेज थेरेपी, साइकोलॉजिकल इंटरवेंशन, फिजिकल इंटरवेंशन कैन हैपन. सो ऐसे ग्रुप थेरेपी से भी बहुत हेल्प होती है. इसीलिए सपोर्ट ग्रुप होते हैं, स्ट्रोक सपोर्ट ग्रुप्स. तो चेक करो कि अपने एरिया में सपोर्ट ग्रुप है स्ट्रोक का. अगर नहीं है तो ऑनलाइन सपोर्ट ग्रुप्स भी पॉसिबल अवेलेबल है. सो आपको उसमें कैसे और घर में क्या करना चाहिए, जैसे कि अफेजिया पेशेंट को समझने में, बोलने में, लिखने में आपको उन्हें कैसे बढ़ावा देना चाहिए, कैसे उनको ट्रीटमेंट देनी चाहिए, वो समझ में आता है. Okay, so you can make some communication boards. You can have constant therapy app or tactics therapy app, or slowly you can have some intervention based with a telerehab, few modules downloaded from the application given by your therapist. Ask for home practice. You use your brain, you will improve faster. That's the main key in aphasia rehabilitation. So आपको क्या करना चाहिए? सिंपल डेली लिविंग ऑब्जेक्ट्स वो लेकर आपको देखना है कि वो बोल पाते हैं, समझ पाते हैं कि नहीं. अगर बंदा इलिटरेट हो, काफी मरीज जहां पे उनको बोलना और समझना आता नहीं है और वो पढ़ लिख नहीं भी पाते हैं, तभी जाकर कुछ एक्सरसाइजेस हम नहीं कर सकते. तब क्या कर सकते हो आप कि नंबर्स या नोट्स या कॉइन्स जहाँ पे लिखा है नंबर्स और कुछ नाम लिखे हैं, वो फैमिलियर नाम लेकर आप पिक्चर और ऑब्जेक्ट को मैच कर सकते हैं. इस तरीके से आप उनका एक प्रकार का मेंटल एबिलिटीज, अटेंशन और एग्जीक्यूटिव फंक्शंस और नेमिंग, मतलब ध्यान देना, समझना, मिलाना और उसके बाद में क्या चाहिए वो पॉइंट ठीक से करना, ये इम्प्रूव कर सकते हो. सो नॉट नेसेसरी हर एक बंदा पढ़ा लिखा होता है वही इम्प्रूव होता है, लेकिन अगर आप पढ़े लिखे तो जल्दी इम्प्रूव हो सकते हो, क्योंकि जितना ब्रेन आपका सीखा है उतने पुर्जे ज्यादा टाइट और अच्छे और स्ट्रांग हो जाते हैं, नेटवर्क स्ट्रांग हो जाते हैं. सो बेटर द लैंग्वेज इज नोन, ज्यादा भाषा पता है उतना जल्दी इम्प्रूवमेंट होता है. ऐसे भी काफी रिसर्च है. आप अगर पढ़े लिखे हो तो भी आपका इम्प्रूवमेंट हो सकता है, और आपके टेक्निक्स, मेथड्स जो हम थेरेपी में कर सकते हैं वो भी ज्यादा तरीके से कर सकता है. सो हैविंग अ लिटरेट पेशेंट एंड हिज नीड्स आर डिफरेंट देन अ इलिटरेट पर्सन. सो वो भी हमें समझना चाहिए कि क्या दिक्कतें हैं पर्सन विद अफेजिया में. आपको ये भी देखना है कि पेशेंट को जस्ट नाउन, मतलब चीजों के नाम यही नहीं काम करने हैं, तो उसके क्रियापद, क्रिया भी हमको पता होनी चाहिए, जैसे कि लिखना, पढ़ना, सोना. क्रियाएं उनके पिक्चर्स और उनके नाम लिखे हुए वो जोड़ने के लिए बोलो. वो कम्युनिकेशन बोर्ड में आप कुछ ऑब्जेक्ट्स जैसे कि चीजें, उनकी पिक्चर्स और कुछ क्रियापद उनके चित्र चाहिए, और वो एक्शन वर्ड से भी आप रोजमर्रे की चीजें, कम्युनिकेशन आप उनको बोल सकते हो, वो आपसे बोल सकते हो. और चीजें बताना और वापस उनसे दोहराना, रिपीटेशन, रिहर्सल बहुत ही इंपॉर्टेंट होता है. ओके, सो वैसे हम थेरेपी अफेजिया में starting from the day he is neurologically stable in the ICU or in general wards, and then later day by day when the patient comes to the OPD, the one-to-one therapy can happen. अगर patient नहीं आ पाता है, हॉस्पिटल में आप नहीं ले पाते हो उनको, तो घर पे टेली रिहेबिलिटेशन के जरिए या फिर होम थेरेपी, होम विजिट से भी काफी हेल्प हो सकता है. तो कभी भी इम्पोर्टेंट फर्स्ट है अर्ली रिहैब, बहुत इंपॉर्टेंट है. उसमें पहली बात, बहुत सारी अफेजिया पेशेंट्स को निगलने में दिक्कत भी होती है, बात करने में दिक्कत भी होती है, और टंग मूवमेंट, जैसे आपकी टंग बाहर आनी, अंदर लेनी, अगर टंग मूवमेंट्स नहीं होती है, जिभ अगर पैरालाइज हो सकती है, तभी भी बोलना नहीं होता है. तो ओरोमोटर एक्सरसाइजेस, मतलब जीभ, लिप्स और चीक्स, और बात करना, आ, ई एंड ऊ, वॉवेल्स ये बोलना, और काफी सारी चीजें होती है जो आप थेरेपी इन अफेजिया, डिजार्थिया, अप्रैक्सिया टारगेट करते हो. सो क्या होता है, किसी को जब अफेजिया होता है तब, ओके, सो द पर्सन विद अफेजिया is not changed inside. He knows what he is. अंदर उसको पता है कि उसको बात करनी नहीं हो रही है, बोलना नहीं हो रहा है, लिखना नहीं हो रहा है, लेकिन सोशल लाइफ अफेक्ट होता है, स्पिरिचुअल लाइफ अफेक्ट होता है, लेकिन आपको उसे ट्रीट राइटली करना है. So many times patients with aphasias, if they don't get proper rehabilitation, do not recover completely. But you have to help them get their respect, right identity, right communication, and involve them in everyday life setting in terms of life participation. So you have a lot of material available on the many websites. So ये हमारी एक वेबसाइट और एसोसिएशन है, अफेजिया एंड स्ट्रोक एसोसिएशन. हम उसमें लोकल लैंग्वेजेस में पेशेंट्स के लिए और उनके फैमिली के लिए क्या करना चाहिए, क्या नहीं करना चाहिए, कम्युनिकेशन बोर्ड, सिंपल एप्स और वर्कबुक्स, रिसोर्सेस हम वहां पे अपलोड करते हैं. और आपको वहां पे समझ में आएगा कि क्या कर सकते हो आप अफेजिया होने पर, कहाँ पे जाओगे, किससे मिलोगे. ओके, सो द टेक होम मैसेज ऑफ फॉर द स्ट्रोक अफेजिया रिकवरी इज अर्लियर द रिहेबिलिटेशन, बेटर द रिकवरी. आप स्ट्रोक होने के बाद काफी भूलते हो, लूज करते हो, लेकिन आप रीगेन भी कर सकते हो अगर आप राइट न्यूरो रिहेबिलिटेशन करके न्यूरोप्लास्टिसिटी इंप्रूवमेंट करने के लिए चांसेस होते हैं. सो you have to give rehabilitation, and throughout the phase of post stroke, acute, फिर 6 महीने में लीशन फेज, और फिर chronic phases भी पेशेंट इंप्रूव करते हैं. राइट ट्रीटमेंट इज वेरी इंपॉर्टेंट. ओके, और हर एक पेशेंट अलग होता है. छोटा बच्चा, उसको स्ट्रोक आया, या फिर अडल्ट जो इंजीनियर है और डॉक्टर है, उसको स्ट्रोक आया, या फिर फार्मर इलिटरेट है, लेकिन एज मैटर करता है, और उसका लीशन कितना बड़ा स्ट्रोक है वो भी मैटर करता है, और थेरेपी आपने कैसे ठीक से दी है, कैसे प्रैक्टिस की है, साइकोलॉजिकल फैक्टर. डिप्रेशन हो तो उसे राइटली ट्रीट करना चाहिए. तो साइकोलॉजिस्ट और साइकियाट्रिस्ट और न्यूरोलॉजिस्ट एंड इम्पोर्टेंटली स्पीच लैंग्वेज थेरेपिस्ट, वो पूरा एज अ टीम काम करते हैं, और टुगेदर वी कैन हेल्प स्ट्रोक अफेजिया सर्वाइवर्स. ओके, और लेट मी टेल यू वन थिंग, यू शुड हैव अ गुड अंडरस्टैंडिंग ऑफ स्ट्रोक. किसे होता है, कब होता है, स्ट्रोक से क्या होता है. so, ये जानने से भी काफी चीजें अपनी हल हो सकती है. कि काफी लोग जिनको पता भी नहीं है उनको स्ट्रोक आया है और बात नहीं कर पा रहे, आप उनसे बोलकर उन्हें हेल्प करो. काफी लोग होते हैं जिनको हाइपरटेंशन है और स्ट्रोक आ सकता है, उनको हेल्प करो कि प्रिवेंट हो, स्ट्रोक न आए, और आगे की डिसेबिलिटी, स्ट्रोक अफेजिया न हो, उसके लिए भी आप हेल्प कर सकते हो. सो दिस इज व्हाट आई वांट टू टेल एंड शेयर. थैंक यू.
Thank you so much, Sonal ma'am, for telling us types of aphasia, how to screen aphasia, how to communicate, how to understand the difficulties, what are the do's and don'ts, how to give the right treatment, and also discussing about what types of therapy we should give. Thank you, ma'am.
Thank you.
Yes. If someone have some questions, they can put it in the chat box so we can discuss it with our speakers.
Yes, one. Yeah, so if you can answer that, Sonal, that will be great. Yeah, even at my end, network is a little flaky today. So can you answer, Sonal?
I did not read, ma'am.
Yeah,
Could
yeah,
I
yeah.
take the question?
So a patient who is bedridden, whether we can bedridden and aphasia because of whatever head injury or a severe stroke. So how can aphasia therapy be given to a patient who is bedridden and caregivers are unable to transport the patient to the therapy center?
Yeah, this is what happens in many severely ill bedridden patients and elderlies also, where they have maximum stroke in old ages or with a severe head injuries or severe stroke. So when they cannot be transferred to the local hospital tertiary center, you can always try to make them sit at the home and have a small ipad or a tab or a computer, and telerehabilitation wise you can avail a speech language cognitive communication therapy. You can also try to have simple signs communication board, where you can have activities of daily living, simple picture based communication board, so one can help her or him point, understand, exchange the picture. So picture exchange system can be given. You can also try to help the person with aphasia and the caregivers communicate effectively for the everyday life skills. So his needs to take the person to the bathroom, to toilet, to show or understand that he is in pain. So how one has to sign, one has to communicate with this picture communication. And obviously telerehabilitation can really help. You can have lots of modules available, aphasia apps available online, which can guide you for therapy in aphasia where the person is not able to reach. So you have a hybrid approach where the person is given some modules and simple videos, do's and don'ts of aphasia therapy, from the severe aphasia or the moderate aphasia. So everything has to be properly mapped by the therapist. Every aphasia is different. One understands, does not speak. Someone doesn't understand, doesn't speak. One may be able to speak fluently, but a jargon, complete gibberish, but does not understand. So it is important, if it is a person who is a bedridden, how he or she is helped. You cannot keep the patient only at home and say he'll improve on its own. So rehabilitation helps. Was that helpful?
Yes, I think, Mr. Uday, I hope your question has been answered. And some training can be given to the caregivers also. But I always feel that when caregivers are to be trained, it should always be two caregivers who are trained, so that that one trained caregiver doesn't have the burden of training the patient.
Yes,
Uh,
ma'am.
Yeah, yeah.
there
Yes,
is one question related to that again.
yeah.
Uh, if the patient is too weak
Hmm.
and if the patient is bedridden,
Hmm.
can we take her to the
Therapy.
rehab center?
Hmm, 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 hmm.
Or what is the time to take her to rehab center?
Yes, Sonal. How do we? And I think Archana also.
Yeah, Archana.
Both of you have to answer that she is bedridden. So how do we take and how do we basically plan the therapy of that patient? That is what you're
Yeah,
asking.
I think
Yeah.
it's more of planning of therapy is what I think the caregiver wants to ask. See, at least in our country, we still don't have very good rehab centers where we can admit the patient and give them all kinds of rehabilitation services. But if you can, if it is possible to transport a patient outside the house for rehabilitation services, it
Expensive.
is quite good. But for bedridden patients who cannot move at all or they are very acute stage, it is always better to give them home services till the time they sit up in bed. I always tell my patients immediately as soon as you can sit and transfer to a wheelchair, come out of your house, because that is the time you have to explore. Your brain has to learn many new things, and you can get you will learn many things once you come outside of your house or your comfort zone. Yes, Sonal, you can also add.
Yes, ma'am, I agree with you. So even when the person is bedridden, the patient is having a high risk population with post-COVID patients,
Yeah.
post-COVID scenario, we don't want our patient to get infected. So many times it happens that they are scared to come for therapy. So I have seen in the COVID pandemic, people are denying therapy. People are not coming to the therapy services. At the same time, many people are not available to give home health services. In that scenario, always make sure that you as a caretaker go to the person who is a right person in tertiary center, a physiotherapist, speech pathologist, psychiatrist, psychologist, neurologist. Do not just sit at home and the person with aphasia or hemiplegia or spasticity, severe depression, abulia, disorientation, so they need to have proper intervention. You can concern the people, get some home program, learn correctly, then have the hybrid approach. Hybrid approach means get some worksheets, get some simple training modules where you can work at home, get some simple communication board made, signs and symptoms based made, get some easy training where you have tele-rehabilitation, one-to-one, one person sitting at home who is at the bed caring and helping him, and the person at hospital. So you can have a hybrid approach work. But a person who is a bedridden and getting him an ambulance on the wheelchair or somewhere he's not able to brought in the very difficult scenarios, it is not feasible. So always make sure that check the right stage where he or she is bought. I always feel that twice a day therapy is mandatory for the person with aphasia, hemiplegia, or and the stroke. But if you have a rehab centers, they're always better. But in India, we have very few rehabilitation centers. Like we have some patients admitted in hospital who are only there for rehabilitation of speech therapy, physiotherapy, occupational therapy. So they are worked well, and then once they are able to eat on their well, swallow on their well safely, communicate effectively, at least take on their own the things, the walk and physical aspects, and then they are discharged. If the key, you have many professionals helping you, many professionals available who can take the caregiver can be trained with them. So that should not be the reason to avoid or get deprived of rehabilitation service, at least in this COVID pandemic and with the bedridden patients, both a risk population.
So I think to combine the answers and to address the query raised by Mr. Uday, I think the first step is to assess her, and second step is to plan what she needs, and then how to make a timetable around her bedridden state. So I think that is what we will need to do. Now, next I'm going to combine Moshmi's and Aman's question. What sort of people are the ones likely to be affected by stroke? And is eating habit one of the factor responsible for stroke? So basically risk factors for stroke. So age is a risk factor. With age the risk of stroke increases. Gender is a risk factor. Unfortunately, males are more prone to vascular events, heart attacks as well as brain strokes. Females, while menstrual cycle is going on, the nature has protected the mother to be. The nature has protected her blood vessels कि कुछ भी हो जाए इसको कुछ होना नहीं चाहिए क्योंकि उसको बच्चों का ख्याल रखना होता है. But as soon as her menstrual cycle ends, her hormonal risk factors become similar to that of a male. So postmenopausally, females and males have almost similar stroke risk. Hypertension and diabetes are extremely important risk factors and they are modifiable risk factor. तुम अपना age नहीं बदल सकते, तुम अपना gender नहीं बदल सकते for stroke, but you can modify hypertension and blood pressure. So good control of blood pressure and good control of diabetes are one of the most important modifiable risk factors. Smoking is a very large risk factor for any vascular event, whether it is cardiac or brain. We always worry about brain and cardiac events, but vascular events can occur in liver, in lungs, in kidneys, anywhere. So when you are controlling your diabetes, when you are controlling your hypertension, and when you are giving up smoking, you are controlling the blood vessel health all over your body. So hypertension, diabetes, smoking. For diet, um, if you're eating too much oily food, if you're eating too much red meat, then that is a high risk diet. And if you're eating too much junk food, you're not eating fresh vegetables, you're not eating fresh fruits, because fresh vegetables and fresh fruits have got these scavenging molecules which clean up the blood vessels from the inside. So vitamin C is an important vitamin which cleans the blood vessels from inside. And similarly, if vitamin B12 deficiency is there in India, we find that young infarcts and young strokes are commoner because because of our changed dietary practices. We end up having vitamin B12 deficiency, and vitamin B12 deficiency is very closely connected to something called as hyper होमोसिस्टीनीमिया. मतलब ब्लड में होमोसिस्टीन की लेवल बढ़ जाती है, और होमोसिस्टीन लेवल बढ़ जाने की वजह से blood becomes thicker. So vitamin B12 is another important factor for controlling and preventing strokes, especially in the young population. Young stroke आया कि हम उसका सीरम प्लाज्मा होमोसिस्टीन और सीरम B12 करवाते ही हैं as a part, whether he is a smoker or not, whether he is diabetic or not. So B12 is one of the important vitamins we look out for. And too much of red meat, too much of oily food, excessive salt intake, which is risk factor for hypertension, again that also becomes important. Alcohol, of course, is also responsible for dyslipidemias, matlab cholesterol ka badna. So alcohol is also a risk factor, but smoking is a bigger risk factor than alcohol as far as stroke is concerned. Then there are other small risk factors, but these are the major ones. A lot curd intake, yes, of course curd intake will help, but too much of anything is bad. तो सब जो हमारी थाली है उसमें लेफ्ट साइड इज फॉर माइक्रोन्यूट्रिएंट्स एंड राइट साइड इज फॉर मैक्रोन्यूट्रिएंट्स. तो सब्जी दाल राइट साइड में होते हैं और चटनी और कोशिम्बीर इज ऑन द लेफ्ट साइड. सो all things have to be taken in correct proportions. So yes, curd is good. And yeah, so that is it. And now this is
Also,
for
can I add, ma'am, one more thing? What I
Yes.
see
हाँ,
many times in the young stroke patients, in the young women 20 to 35, there are a lot of OCP induced hemorrhagic stroke. So many
yes,
women are not aware of the oral contraceptives, their intake, and they have a high risk of having a hemorrhagic stroke, which we have seen CVTs.
yes, correct.
And people should know that. No,
yeah,
ma'am?
correct. And young college going crowd or younger young girls could also take the morning after pill. And morning after pill may appear to be safe, but it is also a hormonal pill. You have to remember that. So if you have a family history of stroke, you have other risk factors for stroke, and then you take the morning after pill. So be sure that that morning after pill is going to interfere with your hormones, and hormones are connected to the thickness of our blood. So yes, thank you, Sonal, for bringing up that topic. So oral contraceptive pills, if you have risk factors, then do consult your doctor to about whether you can take them or not. Now, there is this question by Riaz Memin. I think, Archana, you have to address it. How often we decide about remission in physiotherapy?
Yeah, very nice question, ma'am. I think we should be deciding about reducing the number of physiotherapy sessions or stopping physiotherapy once the patient is functionally independent. Functionally independent is something which means that the patient is able to take care of himself or herself, or is back to his pre-morbid state or near normal life. Physiotherapy treatment doesn't always mean that you have to go to a physiotherapist, take treatments and come back, or a physiotherapist should keep on coming to your house. I always say the caregivers have to understand what is rehab, because it is a long-term thing. It needs to be delivered continuously, and it is going to take time. So everyone, most of the patients keep on asking me की 3 महिने व्यायाम केल्यानंतर बरे होणार का, और 6 महिने केल्यानंतर बरे होणार का. तर it is not time bound, because again, as every patient is different, each patient's needs are different. But you should understand that the most important factor is getting the patient functionally independent, after which you can maybe reduce the physiotherapy treatments.
Thank you so much, Archana, and I hope it answers your question, Riaz. Yes. So I always tell my patients that in neurology, we do not use the word called recovery. We always say improvement. Recovery matlab pehle jaisa banna. It is very tough. What we say is improvement. Is the patient better today than what he or she was yesterday? So that is a very simple formula. कि कल से आज अच्छे है कि नहीं? So every day the caregiver and the patient, they can do this very simple assessment. So that is important. Can we get a team of doctors for rehab regarding questions raised by Mr. Uday in Pune? Yes, Mr. Anand Khedkar, we are working towards that. In fact, the dream project of our NGO is to have a state-of-the-art rehab center in Pune. So let's hope that our dream is because it has to be that indoor center which Dr. Archana talked about right now. So we hope that we get enough opportunities and support to be able to realize that dream. Sonal
I'm
has
so glad, ma'am, when I had to start my video. I should tell you all it is something which is actually needed for the day
yes,
in
yes,
India,
yes,
and it will not, it has to have a complete umbrella of rehabilitation. The
yes,
patient should come in and go back to near normal status. As ma'am said, it is recover. It's not completely recovery, but they get better each day.
okay.
And
Hmm.
yes, we all should definitely try for that.
Yeah, yeah. So we let us see something good will come up. Now Sonal has also made the statement. Relapse is seen in seizures post stroke and recurrent stroke patients and few severe stroke patients. Yes, plateau happens. Correct. Then Swarnali has commented. I wanted to know that if a person with hypertension suffers a minor brain stroke, is it possible to get cured in home without seeking help from hospital? So, Swarnali, there is something known as a natural healing, but natural healing can occur in small strokes. But then, by just waiting for natural healing to take place, you might be losing out on the golden time period for neuroplasticity. So, even if it is a minor brain stroke, I would suggest that you get in touch with a physiotherapist. Which city are you from, Swarnali? You can post which city you are from so that if possible either Dr. Archana or Sonal could guide you also. So don't wait for that natural healing luck factor to happen. The patient needs to be assessed, has to be seen by a rehabilitation person, especially if language is there, then a language therapist. If there is neuro deficit, then a neurophysiotherapist should see. And if Dr. Archana is available for teleconsultation, then of course she can also help you in assessing. So do approach us if you need that help. Swarnali is saying she is in Pune. So
Okay. Yeah.
yeah, so Dr. Archana will
Can
definitely.
definitely help. Yeah, we can definitely.
Definitely. So yes, Sonal, we will work on that.
So
IFNR.
one more point I wanted to just highlight here is
Yeah.
many patients with aphasia, hemiplegia,
Hmm.
where they are not improving in
Hmm.
just 1 or 2 or 5 sessions,
Hmm.
people drop out and they feel that आप कुछ ठीक नहीं कर रहे हो, हम ये डॉक्टर जाते हैं. So they are people are doctor shopping. It's
Hmm.
not correct. You have to have patience, and patient takes time. So it's a slow process. With financial burden, people drop out, and also when they have no faith in rehab.
Hmm.
So it is important to educate caregivers rightly.
Hmm.
And then the target, how much time one can take, it's different. Every patient requires differently. An outcome can vary in the stroke aphasia, stroke hemiplegia, stroke visual impairment, and even the stroke related catastrophe also.
Correct. A problem that I find as a neurologist, I find that there is a big communication gap. So when a doctor says improvement, the patient's caregivers and the patient starts thinking about recovery. So when we say improvement, as I said, we are talking about is the patient better than what he or she was yesterday. And when the caregiver hears improvement, they start thinking ki very rapidly that patient is going to be as he or she was before the event occurred. So this realistic goal setting is an important step, and I feel it needs to be done within the first two visits of the patient and the caregiver. and caregiver's motivation is a very challenging task because caregiver is being exhausted financially, socially, emotionally, and that becomes a major task, and that's why we are working on caregiver health as well, and setting up a system for support of the caregiver, because caregiver is actually a secondary patient whose file is never made in the hospital. Caregiver is suffering but doesn't have the luxury of treatment. So caregivers need support, and very often they are the decision makers of dropping out. So who is taking the decision of dropping out? Someone who is actually himself or herself a patient but doesn't know it. So caregiver mindset is a big um, knowledge based for us to discover, and we are working on caregiver health as well for that. So yes, so like Swarnali now, she is the caregiver. So she needs hand holding. That is what she has reached out to us for hand holding for her issues. So that is how it works, caregiver help, and their decision making is connected to the patient receiving therapy or not. And unfortunately, if the patient doesn't improve, the caregiver is going to continue to suffer. So it's all connected, and that is a vicious cycle. So yeah. So yes, it has been a good discussion. Any more questions?
Ma'am, I want to ask a simple question.
Yes, Aman.
मैम कौन से केसेस होते हैं जिसमें ना ह्यूमन का हीमोग्लोबिन रेट उसके एवरेज से ज्यादा होता है?
Okay, so this is a very important question because this is called polycythemia.
Okay.
Hemoglobin, hemoglobin being more than normal. Anemia is low hemoglobin. Polycythemia is high hemoglobin.
So I have that. मुझे 2-3 बार मैंने टेस्ट भी किया और मैं being a zoologist I did some मतलब लैब में भी मैंने टेस्ट किए थे, तो it is above 18 grams.
So the easiest thing for you to do is approach a blood bank, and if they can take your blood, to donate blood every 6 months. But you need to get to the bottom of this. The commonest cause of polycythemia is smoking. But I know you, and I don't think you're a heavy smoker.
Yes, ma'am. No.
Okay. Yeah. So then genetic causes have to be ruled out. You have to meet a hematologist, and you have to rule out genetic causes, because if it is a genetic disorder, then your family members need to be screened, and bloodletting is the simplest treatment for it. And if polycythemia is remaining static, hemoglobin जो 18 है आपका, वो अगर 18 के 18 में ही रह रहा है, या फिर every 6 months you donate blood and because of blood donation it remains 17, okay, so then nothing needs to be done. But if it is constantly increasing gradually, then you will need your bone marrow to be tested, and you will need another types of therapy. So you have to once meet the hematologist, or you have to get to the bottom of this, whether there is a genetic cause or what we call as myelodysplasia, where the bone marrow is unnecessarily producing extra RBCs. Another reason of polycythemia is people who live at high altitudes. They are continuously exposed to low oxygen. And so the body, to compensate for the low oxygen available, creates more trucks for carrying hemoglobin, and which are carrying oxygen. And which is the truck for carrying oxygen? Hemoglobin. Hemoglobin is the truck which carries oxygen to the whole body. तो अगर oxygen कम है तो truck की संख्या बढ़ा दो, तो oxygen कम है तो hemoglobin बढ़ा दो. So low oxygen is another area where people living in those areas can have higher hemoglobin, but you are not living there. So then हमारे लिए genetic cause है कि नहीं देखना जरूरी है. You have to get it evaluated. And simplest thing is to donate blood. I know someone in Nagpur who is an engineer, and he has donated blood more than 100 times, not because he has high hemoglobin, but he likes to do that as a service. So
I did that before, लेकिन तब ना मेरा weight कम था, so that's why I stopped there. लेकिन फिर बाद में जब weight बढ़ा तो मैंने 2 या 3 बार दिए हैं, मतलब donate किया है, but it is constant. और मैं ये पूछना चाहता हूँ कि हीमोग्लोबिन का रेट अगर ज्यादा हो गया तो क्या ये स्ट्रोक हो सकता है? क्या stroke?
Yes, it is one of the risk factors for stroke. Polycythemia is one of the, जो मैंने बोला ना rare factors है कुछ risk factors, उसमें polycythemia, vasculitis, ये सब चीजें आती है. So polycythemia is one of the risk factors, and you need to address it. You cannot sit on it.
Okay, ma'am.
Okay.
Thank you.
Yeah, it was a very important question. Thank you so much. So if there are no more questions, I will turn over back to Shubhashri.
Yes.
Yes, Shubhashri.
It's my honor to propose the vote of thanks. I, on behalf of NIF and the volunteers, extend a very hearty thanks to our honorable speaker who created a huge and big awareness about brain stroke. Thank you so much, Purnima ma'am, Sonal ma'am, and Archana ma'am. Literally, you created a big awareness. And also the people who joined us today, a big thumbs up to you all for joining us. Yes, and also for further events, you can visit our website, visit our Insta page, and visit FB too. Thank you so much. Over to you, ma'am, if you want to say something.
Thank you, Shubhashri. And let me tell everyone that Sonal is very passionate about her work as a language therapist, and Dr. Archana is very passionate about her work as a neurophysiotherapist. So, and I'm very passionate about, in general, holistic neurology care. So today has been a very passionate session, and it was very energized, and I have myself enjoyed a lot, and was very intrigued that so many people came out and asked their questions. And we need to reach out to more and more people, and so many people must be having so many questions in their mind. So yes, we need to reach out. So each one of you do talk about today's program to one person. So as Sonal Chitnis ma'am has said, each one teach one. आज हर किसी ने जाके एक किसी व्यक्ति को बताना है कि हमने ये सब सुना और ये सब समझा. So thank you so much. Also visit our YouTube channel, which is by the name of Niche Advocacy Foundation. And this today's program was live on that also. So you can share that link with others. I will be putting it on the WhatsApp group. So thank you and have a good night and a good week ahead of you. Thank you, Archana, and thank you, Sonal, once again for being a part.
Thank you, ma'am. See you soon. Thanks, all.
Thank you so much, ma'am. Stay safe all. Thank you.
Bye-bye.
Thank
Bye.
you. Thanks all of you.